So let's kick off with our first speaker. It gives me great pleasure to introduce Allison Boyle, who's an advanced pharmacist at NHS Greater Glasgow and Clyde in Scotland. Has also been working for a long time with the University of Liverpool Drug Interactions website, which I'm sure you all use on a regular basis. Allison, over to you.
Oh, thank you. Good morning, everyone. Thank you to INSU for inviting me to share our experience from Glasgow. Of a multidisciplinary team approach to retreating patients not achieving SVR after hepatitis C treatments. I'd like to thank my co-authors in this work, as well as our patients and the teams that we work with in delivering hepatitis C treatment in Glasgow. And these are our disclosures at the bottom. Okay, so everyone will be well aware that hepatitis C direct-acting antiviral treatment has revolutionised hep C treatment, and treatment with these regimens achieve very high rates of sustained viral response and cure. However, there remains a small number of patients who do not achieve SVR following treatment. For those with a positive hep C RNA after treatment, it can be difficult to ascertain whether this is a result of true treatment failure or whether non-adherence to treatment has played a part, or whether there has been a risk of reinfection. Many of our patients do not have end of treatment results available, and depending on the treatment setting, either pre and or post blood results may be via dry blood spot testing, so genotype is not available. So all of these factors can contribute to uncertainty in determining how to retreat patients not achieving SVR. In addition, patients may not attend for SVR bloods as scheduled within the first with the first sample post-treatment being many weeks or months after the after SVR 12 time point, increasing the potential risk for reinfection. To avoid retreating all patients with positive PCR post-DA treatment with second-line regimens, which are generally more expensive and can be more complex to take, we devised criteria to support prescribers to take a pragmatic approach to decide whether retreatment could be with the first-line regimen or whether a further discussion within our treatment failure MDT was required. So we have a flowchart here, and you can see that we take into consideration whether there's a risk of reinfection. If there are venous samples available, we can check genotype and compare whether the genotype has changed, so indicating it's a likely risk of reinfection. Again, if we have venous samples available, we do have access to resistance testing within our virology teams, and so we can request NS5A resistance if the genotype has remained the same. The majority of our patients at the moment have the hep C treatment dispensed via community pharmacies, so we usually have a relatively good idea of adherence to treatment, and again that will inform the treatment decision. For situations where it's not as clear-cut, we have a treatment failure or DA failure MDT. This is coordinated by an advanced pharmacist alongside hepatology and ID consultants, clinical nurse specialists, and a consultant virologist. As the pharmacy team will feed back on adherence via the community pharmacy dispensing records, and can identify any potential DDIs that may have contributed to the treatment failure, and also whether any DDIs will influence the treatment choice for retreatment. The clinical nurse specialist will inform us of whether there is any potential for reinfection, and also whether further or additional adherence support might be helpful for the second treatment. If we do have resistance samples available, or we've been able to check for resistance, and the virologist will review them. They can also compare sequences pre and post treatment to identify whether relapse or reinfection is more likely. And then the consultant team will obviously consider the sort of clinical implications of under-treatment and assess severity of underlying liver disease, as well as the need for ongoing follow-up. And then as a team, we'll make the decision to whether we would go for a first-line retreatment choice or second-line, or potentially defer to a later date. So the aim of this review was to evaluate the outcome of this approach to retreating those with a positive hepatitis C RNA at or beyond the SVR time point after initial treatment course, and also to compare the outcomes of those who receive first versus second line therapy. So we used our local Hep C database to identify individuals with 2 treatment episodes with DAs but no confirmed SVR after the first treatment episodes, and they remained the same genotype. We collected data on whether the treatment course was completed, the time from end of treatment to the positive results, any risk of reinfection, whether patients were on concurrent opioid agonist therapy, if it was available, the NS5A resistance testing, and whether there were mutations present. We recorded whether we used the first or second line treatment regimen and the outcome of the second treatment. So we identified 185 patients from our database and excluded 7 who had a genotype switch, which we deemed to be a definite reinfection, leaving 178 patients. Of the 178 patients, 9% had a positive Hep C RNA at the end of treatment. Around 24% had a negative end of treatment result, but subsequently had a positive Hep C test at the SVR12 time point. 37% of patients had a negative Hep C RNA at the end of treatment, but did not attend for the scheduled SVR12, and then at the next presentation had a positive Hep C RNA results. And then finally, 31% of patients didn't have an end of treatment result, but at some point, either at SVR or beyond, had a positive Hep C RNA. So 27% of the patients had documented risk factors for reinfection, and obviously it was a retrospective review, so the documentation was not 100% accurate. So the actual risk of reinfection is likely to be higher and would have been discussed within the MDT. 10% of patients had HIV co-infection, about 44% were on concurrent opioid agonist therapy. 67% of the group had NS5A resistance testing sent, and of those, 44% had mutations present, NS5A resistance present. So about 29% of the whole cohorts had cirrhosis, and the intention to treat SVR was 87%. 63% of the patients received retreatment with a first-line regimen. A similar similar proportion of patients with cirrhosis in this subgroup, and the intention to treat SVR was 86%. And these are the first-line regimens that we used, and these were prescribed according to local and national guidance at the time. The remaining 37% of patients were retreated using second-line regimens. Again, similar proportion of patients with cirrhosis, and the intention to treat SVR was 88%. The majority of patients who were retreated with second-line regimens received sofosbuvir, velpatasvir, voxilatravir, and there was no significant difference in intention to treat SVR between both groups. The reasons why patients did not achieve SVR after the second treatment course are in the table here. So a small number of patients in both groups had no SVR bloods checked. A small number of patients discontinued treatment early. 5% of patients in the first-line treatment group were deemed to have a virological failure, and 3% within the second-line treatment group. When we excluded those who did not achieve SVR for reasons other than virological failure, which was 16 patients, we had a per-protocol SVR in the total cohort of 95%, with 94% of patients receiving first-line treatment achieving SVR and 97% in the group receiving second-line regimens, and there was no significant difference between the groups. So just to conclude, this MDT approach to retreating patients allows for the majority of those not achieving SVR to be retreated with the first-line regimen. And as I mentioned previously, the second-line regimens are generally more expensive and can be more complex. So this strategy allows us to manage a greater number of patients with straightforward, cost-efficient therapies, potentially allowing us to treat more patients overall, and it also reserves the more intensive second-line failure regimens for when they're needed. This approach achieves a high rate of SVR, and reassuringly, there's no significant differences in SVR rates between those treated with first and second-line treatment options. So happy for questions, or you welcome to email me if you prefer.
Thank you, Alison. Beautifully timed. If anybody's got any questions, please come to the microphones. Otherwise, you can post them via the app. Whilst they're thinking, one of the things that we've noticed in patients, anecdotally, it's not proven, is that patients who fail treatment may often have underlying undiagnosed HCC, possibly because of the arterial supply to the cancer bypassing the drugs. Did you find any cancers in any of those patients, that were HCCs in those patients who failed treatment?
Yeah, I'm not sure that we've looked into that so far. We have a further group of patients who have had 3 or more treatment episodes. We're still looking at the whole cohort to sort of look at the underlying reasons, and we've got an abstract at ASLD for that. So yeah, at the moment I don't have that information, sorry.
Fortunately, I'm not going to make it to Washington.
Oh.
So I'll wait for it in the journals. Do we have any other questions from the floor for Alison? Well, if not, thank you very much for keeping to time. And